and welcome. Have you ever really truly stopped to think about what happens when you break a bone? We tend to think of it as this single event, a sharp crack, a moment of just searing pain, followed by a trip to the hospital, a cast, and then, a slow recovery. But that's just the surface. The reality is, it's this breathtaking story. It's a story of biological violence, of microscopic engineering, and of some of the most incredible resilience you'll find in the human body. Today, we're not just doing a quick overview. No, we are diving headfirst into a really comprehensive exploration of the entire life of a fracture. We're going to start with the physics of that initial violent snap. Then we'll walk through the body's truly miraculous four-act play of healing. And finally, we'll look at the medical marvels that help put us all back together again. This is the complete story. Think of it as a deep, detailed masterclass. So please, get comfortable and let's get started. So, our journey today is laid out in 6 parts, and it's designed to follow the complete life of a fracture, logically, from beginning to end. First, we'll dig into the anatomy of the break itself. Then, we'll look at the body's amazing blueprint for healing. After that, we'll explore the catalog of potential complications, what happens when things go wrong. Then, we'll get into the art of medical repair. We'll also cover some uniquely dangerous fractures where location is everything, and we'll finish up with a really practical look at life after one of the most common orthopedic surgeries, a hip replacement. All right, let's dive into part 1, the anatomy of a break. See, before we can even begin to understand the magic of healing, we have to build a solid foundation. We need to learn the language. We need a way to describe exactly how a bone, this incredibly strong material, can actually fail. What exactly is a fracture? What causes it, and how on earth do we even begin to classify the almost infinite ways a bone can break? Okay, so let's start with the absolute core definition. A fracture is simply a discontinuity of the bone. But that simple word, discontinuity, it hides an incredible amount of drama. Let's really think for a second about what bone actually is. It is not just some inert piece of rock inside of us. It is a living, breathing, dynamic composite material. It has this flexible matrix of collagen protein that gives it its resilience, almost like the rebar you'd find in reinforced concrete. And then woven into that flexible collagen is this crystal structure of mineral salts, mostly something called hydroxyapatite, which gives it its incredible compressive strength. So to create a discontinuity in a material this sophisticated, it requires an enormous amount of energy. The force of an impact has to completely exceed the bone's ability to bend and absorb that force. Now, of course, not all breaks are the same. A complete fracture means the bone is broken into 2 or more totally distinct pieces. The structural integrity is just gone. An incomplete fracture, on the other hand, that's more like a crack that doesn't go all the way through. A perfect example of this, which we'll talk about more later, is the green stick fracture. Just imagine taking a young, green branch from a tree and trying to snap it. It doesn't break cleanly, does it? One side kind of splinters while the other side just bends. Well, that's exactly what happens in the more flexible bones of children. So you see, this one simple definition covers the entire spectrum of damage, from a tiny, tiny hairline stress fracture that's invisible to the naked eye, all the way to a bone that has been shattered into a dozen pieces. So what actually causes a bone to fail? Well, the most obvious answer, the one we all picture, is trauma. This is the high-energy event, a fall from a height, a car accident, a severe crushing injury. This is a case where an overwhelming external force is applied to a perfectly healthy, normal bone. But what's really fascinating are the other causes, where the bone is actually being weakened from the inside out. This makes it vulnerable to forces it would normally just shrug off. Take bone disease, for example. The most famous one is osteoporosis. And this isn't just weak bones. It's a very specific deterioration of the bone's internal microarchitecture. You see, healthy bone has this dense, honeycomb-like structure on the inside. In osteoporosis, the little struts of that honeycomb become thinner, and some of them just break down entirely. This makes the bone porous, brittle, and incredibly fragile. A person with severe osteoporosis might suffer a major hip fracture just from twisting the wrong way while standing up. Then you have malnutrition. Bone is a living tissue, and it's in a constant state of flux. It needs a steady supply of raw materials. We're talking primarily calcium and vitamin D, just to maintain its density. Without them, the body simply can't build or repair bone effectively. And then there's this controversial but really interesting point about carbonated beverages that have phosphoric acid. Now, the theory isn't that the acid is directly eating your bones, it's more subtle. The idea is that consuming very large amounts of it can alter the body's delicate calcium to phosphorus ratio. And that imbalance can trigger hormonal changes that lead to calcium being pulled out of the bones to rebalance the chemistry in your blood. It's a very subtle, long-term effect. And finally, medication side effects. Long-term use of certain drugs, like corticosteroids, is a very well-known cause of decreased bone density. These drugs can disrupt the normal cycle of bone breakdown and rebuilding, essentially tipping the scales in favor of breakdown. This leads to a much higher risk of fracture. So you see, a fracture is often a story not just about force, but about vulnerability. To properly treat a fracture, doctors need a very precise language to describe it, and they classify breaks by asking a few key questions. First up is exposure. Is it open or is it closed? A closed fracture is one where the skin is completely intact. But in an open or compound fracture, a sharp bone fragment has literally pierced through the skin. This is a total game changer. It's no longer just a broken bone, it's now a contaminated wound. The bone is exposed to all the bacteria from the outside world, creating a massive risk of a deep, difficult-to-treat bone infection called osteomyelitis. Second, they ask about alignment. Is it displaced or non-displaced? A non-displaced fracture is a pretty clean break where the pieces are still perfectly lined up. But a displaced fracture is one where the bone ends have shifted out of their normal anatomical position. They might be angled, they could be shortened because powerful muscles have pulled them past each other, or they could even be rotated. These almost always require something called a reduction, where a doctor has to physically realign the pieces. And finally, what's the pattern of the break itself? This really tells the story of the force that caused it. A transverse fracture is a clean, horizontal break, usually from a direct, sharp blow. An oblique fracture is diagonal, from a force that hit at an angle. A spiral fracture has this corkscrew shape, and it's caused by a twisting or rotational force. You see this a lot in skiing accidents, where the foot is locked in a boot and the body twists around it. A comminuted fracture? That's where the bone is broken into 3 or more pieces, often just shattered, from a very high energy impact. And of course, there's that green stick fracture we mentioned earlier, the incomplete break we see in kids. So, using this language, a doctor could describe an injury as, say, a closed, displaced spiral fracture of the tibia. And in just those few words, an entire crystal clear picture of the injury and the forces that caused it comes to life. The signs of a fracture are often what you'd expect, but each one tells a really important physiological story. The pain. It isn't just from the bone ends themselves. It's from the surrounding muscles going into this protective, involuntary spasm that can be unbelievably intense. And that spasm is closely followed by edema and swelling. When a bone breaks, its rich blood supply is torn, causing a lot of bleeding into the surrounding tissues. This internal bleeding, well, it manifests visually as ecchymosis, which is just the medical term for bruising. Then you have deformity. An arm bent at a completely unnatural angle is probably the most obvious sign that the underlying structure has failed. Shortening can also happen, especially in something like a thigh bone fracture. The massive quadriceps muscles can spasm and pull the lower bone fragment upwards, causing it to overlap with the upper fragment. This can make the leg appear noticeably shorter. Loss of function is a given. The limb simply cannot support weight or move correctly. But one of the most definitive and frankly unsettling signs is something called crepitus. That's the palpable, sometimes even audible, grating sound and feeling of the broken, raw bone ends rubbing against each other. It is an absolutely unmistakable sign of a fracture. And finally, in the most severe cases, like a major pelvic or femur fracture, the amount of internal bleeding can be so massive, we're talking multiple liters of blood, that the person can go into life-threatening hemorrhagic shock. Each one of these signs is a clue to the chaos that's unfolding right beneath the skin. Okay, part 2, the blueprint for bone healing. We've just talked about all the violence and damage of the break itself, but now we get to pivot to something even more remarkable. The body's innate and incredibly sophisticated process for repairing that damage. We're going to explore the body's 4-stage blueprint for literally rebuilding itself from the inside out. This isn't just sticking 2 pieces of bone back together with glue. This is a masterpiece of biological engineering that unfolds over months. Bone healing is essentially a 4-act biological play, and it begins the very instant the fracture occurs. Step 1 is hematoma formation. When the bone breaks, blood vessels are torn, and blood just floods the fracture site. This forms a massive clot called a hematoma. Now, this isn't just a bruise. This hematoma is the critical foundation for everything that follows. It seals off the damaged area, and the clotting proteins within it form a sticky fibrin meshwork. This mesh acts like a biological scaffold, trapping platelets and providing a structure for the cleanup crew and the construction crew to move in. Within just hours, this scaffold is teeming with inflammatory cells that get to work cleaning up debris. Step 2 is cellular proliferation and callus formation. This is where the real rebuilding begins. Stem cells from the lining of the bone and the surrounding tissues are activated. They arrive at the fracture site, and they differentiate into bone-building cells called osteoblasts and cartilage-building cells called chondroblasts. These cells work furiously, creating what's known as a fibrocartilaginous or soft callus. It's this rubbery, semi-rigid bridge of cartilage and fibrous tissue that connects the broken bone ends. Now, it's not nearly strong enough to bear weight, but it's a crucial step. It provides the fracture with its first real stability, almost like a natural internal splint. Then comes step 3, ossification, or the hardening phase. The soft callus is now systematically replaced by hard bone. This is a process called endochondral ossification, and it's the very same process the body uses to form most of the skeleton in the womb. Osteoblasts move in and begin depositing calcium and phosphate minerals into the cartilage matrix, transforming that soft, flexible callus into a hard, bony callus. On an X-ray, this is the point where you can finally see that the bone has bridged the gap. The fracture is now considered clinically healed, but the body isn't done. The final act, step 4, is remodeling. The bony callus is often bulky and irregularly shaped, kind of like a rough weld on a piece of metal. Over many months, and sometimes even years, the body meticulously refines this structure. A different type of cell, the osteoclast, arrives to resorb or basically carve away all the excess bone. As this is happening, osteoblasts are laying down new, dense, and highly organized compact bone. And what guides this whole process? Mechanical stress. According to something called Wolff's Law, bone adapts to the loads placed upon it. Every single step you take sends signals that tell the osteoclasts and osteoblasts exactly where to add or remove bone, sculpting it back to its original shape and strength. Incredibly, a fully remodeled bone can often be even stronger than it was before the injury. All right, part 3, a catalog of complications. Now, while that 4-step healing process is absolutely incredible, it is not foolproof. The path to recovery is filled with potential pitfalls, and sometimes things go terribly wrong. Understanding these risks is absolutely critical to appreciating why the proper medical management of a fracture is so incredibly vital. These complications can range from just a minor delay in healing all the way to a full-blown, life-threatening emergency. We're going to begin with one of the most feared and urgent complications in all of orthopedics, compartment syndrome. To really get this, I want you to think of the muscles in your forearm or your lower leg. They aren't just floating around in there. They are bundled into compartments by this tough, leathery, and completely inelastic sheath of connective tissue called fascia. Now, inside each of these tight compartments, you have muscles, you have nerves, and you have blood vessels, all packed in together. After a fracture, you get massive swelling from bleeding and inflammation. But this swelling is happening inside one of these unyielding fascial compartments. Since the fascia can't stretch, the pressure inside that compartment just skyrockets. This pressure can climb so high that at first squeezes the veins shut so blood can't get out. Then the pressure rises even more until it actually overcomes the arterial pressure, squeezing the arteries shut and cutting off all blood flow and oxygen to the muscles and nerves that are trapped inside. This is a true medical emergency. The clock is absolutely ticking. Within just a few hours, the oxygen-starved tissues begin to die. This can lead to permanent nerve damage, muscle death, and may even require amputation of the limb to save the patient's life. And the pressure can come from internal swelling, or it can even be caused by something external, like a cast that was applied too tightly before all the swelling had peaked. Recognizing this emergency early is the absolute key to saving a limb, and clinicians are trained to look for the classic warning signs known as the 6 Ps. The first and most important P is pain. And this is not the normal aching pain of a fracture. This is a deep, burning, excruciating pain that is completely out of proportion to the injury and, critically, is not relieved by pain medication. The single most specific sign is agonizing pain on passive stretch. So, for example, if a doctor gently flexes a patient's wrist and it causes just unbearable pain in their forearm muscles, that is a massive red flag. The next P is paresthesia. These are the abnormal sensations like tingling or numbness, that pins and needles feeling, which is a sign that the nerves are being starved of oxygen. Then comes pallor, which is paleness of the skin, and poikilothermia, which just means the limb becomes cool to the touch. These are both signs that the arterial blood flow is being compromised. The final 2 Ps are very late and very ominous signs. Paralysis, or weakness and loss of movement, indicates that the muscles and the nerves are already starting to die. And the very last sign, pulselessness, a diminished or totally absent pulse below the injury, is a catastrophic finding. It means the arterial supply has been completely cut off, and the window to save that limb is closing very, very rapidly. Another major risk after a fracture, especially of the pelvis or the legs, is the formation of blood clots. The immobility that comes after an injury creates the absolute perfect storm for this to happen. The first stage is a deep vein thrombosis, or a DVT. This is when a clot forms in one of the large, deep veins of the leg. It's a localized vascular problem. The leg might become swollen, painful, warm, and red. Now, while a DVT definitely needs to be treated, it is manageable. The real mortal danger is what can happen next. A piece of that DVT can break off, becoming what's called an embolus. This free-floating clot then travels through the wider veins up into the heart, which then unsuspectingly pumps it directly into the pulmonary artery and out into the lungs. Once there, it gets wedged in the branching vessels, blocking all blood flow. This is a pulmonary embolism, or PE. It is not a local problem anymore. It is a life-threatening cardiopulmonary emergency. The patient can experience a sudden severe shortness of breath, a sharp chest pain, and a racing heart. A large PE can cause sudden death. It's a terrifying illustration of how a seemingly contained problem down in the leg can escalate into a systemic crisis up in the lungs. Now, fractures of the long bones, like the femur or the tibia, carry a unique and particularly insidious risk: fat embolism syndrome, or FES. The marrow cavity of these long bones is rich with fatty marrow. When the bone shatters, globules of this fat can be forced into the torn blood vessels and enter the circulation. The problem is, these fat globules are too big to pass through the tiny capillaries of the lungs. The progression of FES is really a timeline of catastrophe. The early findings are all respiratory. As the fat clogs up the lung capillaries, it causes a severe inflammatory reaction. The patient develops hypoxemia, which is low blood oxygen, shortness of breath, and rapid breathing. Then, some of the smaller fat globules might manage to squeeze through the lungs and travel to the rest of the body, including the brain. This leads to the later findings: neurologic abnormalities. The patient becomes confused, their mental status declines, and they can even have seizures. And finally, the last and most classic component appears: a petechial rash. This is a very distinctive rash of tiny pinpoint red dots that are caused by blockages in the tiny capillaries of the skin. It typically appears on the neck, the upper chest, and even in the eyes. This triad of respiratory failure, neurologic changes, and a petechial rash is the absolute hallmark of FES, a rare but truly devastating complication. Sometimes the complication isn't some dramatic emergency, but a quiet failure of the healing process itself. If the bone healing takes significantly longer than the typical time frame for that particular injury, it's called a delay of union. Healing is happening. It's just happening in slow motion. Now, if the bone fragments heal completely, but they heal in a misaligned or incorrect position, that's called a malunion. This can lead to chronic pain, arthritis, and a permanent loss of function. And in the worst-case scenario, the healing process can just stop altogether, leaving the bone ends completely unattached. This is a non-union. A fibrous, scar-like tissue fills the gap instead of bone, and this results in a persistently unstable and painful false joint. A whole lot of factors can contribute to these failures. Age is a major one, as our healing potential just decreases over time. Smoking is a huge culprit. Nicotine constricts the tiny blood vessels that are absolutely essential for bringing oxygen and healing cells to the fracture site. Poor nutrition, infection, certain medications like steroids, and inadequate immobilization. If the bone ends are allowed to move around too much, all of these can disrupt that delicate biological symphony of healing and lead to one of these really frustrating outcomes. All right, part 4, the art of fracture repair. After that whole catalog of what can go wrong, let's turn to the solution. This is where we get to explore the incredible toolkit of modern orthopedics. This section is all about how medicine intervenes to support and guide the body's natural healing blueprint, making sure that bones heal in the correct alignment with the stability they need to become strong and functional once again. The first and most critical step in any fracture repair is something called reduction. That's the medical term for getting the displaced bone fragments back into their proper alignment. And there are two main ways to do this. The first is called closed reduction. This is a non-surgical technique where a doctor uses their hands to manipulate the limb, applying traction and pressure from the outside to coax the bone fragments back into place. Once it's aligned, the limb is then immobilized with a cast or splint. Now, for more complex, unstable, or badly displaced fractures, open reduction is required. This is a surgical procedure. The surgeon makes an incision, directly looks at the bone fragments, and meticulously puts them back together like a jigsaw puzzle. This is almost always followed by internal fixation, where hardware like metal plates, screws, or long rods placed down the center of the bone are used to hold the pieces rigidly in place while they heal. This entire procedure is famously known as an ORIF, open reduction and internal fixation. For some very severe fractures, especially those with a lot of soft tissue damage, a device called an external fixator might be used. This is a frame that sits completely outside the limb, and it's connected to the bone by surgically inserted pins. Caring for one of these is incredibly intensive. The two highest priorities are preventing infection and monitoring circulation. Because those pins create a direct pathway from the outside world straight into the bone, the pin sites have to be meticulously cleaned and monitored constantly for any sign of infection. We're talking redness, swelling, warmth, or any kind of drainage. And just as important are frequent neurovascular checks, assessing for those 6Ps to make sure the device or the swelling isn't compromising blood flow or nerve function. Beyond that, patients have to follow very strict weight-bearing instructions to avoid damaging the fixation. And they're taught isometric exercises, tensing muscles without moving the joint to combat the severe muscle atrophy that can happen during long periods of being immobilized. For most non-surgical fractures, the cast is the classic tool for immobilization, but even here, there's a choice to be made. Modern fiberglass casts are pretty much the standard these days. They are incredibly lightweight, they're strong, they're water-resistant, and they harden within just a few minutes. Plus, they come in all sorts of bright colors, which is a small but welcome bonus. Traditional plaster casts, however, they still have their place. They're much heavier, not at all water-resistant, and they can take a full 24 to 72 hours to fully harden, and during that time, they have to be handled really carefully to avoid creating pressure points. So, why would anyone use them? Well, their one major advantage is that plaster is far more malleable when it's wet. A skilled clinician can create a much more detailed, custom mold with plaster, which can be absolutely critical for certain complex fractures in the hand or the foot that need to be held in a very precise position to heal correctly. It's a classic trade-off between modern convenience and old-school precision. Before a definitive repair can be done, traction is often used to help align a fracture and, crucially, to overcome those painful muscle spasms. The basic principle is a pulling force applied to the limb, which is balanced by a counter-traction force, and that's usually just the patient's own body weight. Skin traction is the less invasive method. A force is applied using straps, boots, or cuffs that are attached to the skin. The most common example is something called buck traction, often used temporarily for hip fractures. Now, because the force is being transmitted through the skin, there's a pretty low limit to how much weight can be used, usually less than about 8 kilograms to avoid damaging the skin. For much stronger and more direct pull, surgeons use skeletal traction. In this case, a metal pin or a wire is drilled directly through the bone, and the traction weight is attached to that pin. Because the force is being applied directly to the skeleton, much higher weights, up to 18 kilograms or even more, can be used. This allows for the kind of long-term, powerful traction needed for severe fractures of the femur or for stabilizing the cervical spine. Okay, part 5, managing specific dangerous fractures. We've covered all the general principles, but with fractures, location is everything. A break in certain parts of the body carries unique and far more severe dangers that extend way beyond the bone itself. These are high-stakes injuries where a deep understanding of the surrounding anatomy is absolutely critical to preventing a catastrophe. 2 fracture zones are notoriously high risk. First, the elbow. The elbow joint is an incredibly crowded anatomical neighborhood. The median, radial, and ulnar nerves, which control all the function in your hand, pass through this very small space right next to the bone. A displaced elbow fracture can easily bruise, stretch, or even sever these nerves, leading to permanent paralysis and loss of sensation in the hand. That tight space also makes it a prime location for the development of that devastating compartment syndrome we discussed earlier, which in the forearm has a specific name, Volkmann contracture. This can cause the muscles to die and scar down, pulling the hand into a permanent claw-like deformity. But even more immediately life-threatening is an unstable pelvic fracture. The mortality rate for these injuries can be as high as 30%. Why so high? 2 reasons. First, catastrophic bleeding. The pelvic ring is lined with this rich network of massive arteries and veins. When that ring is broken, the sharp bone edges can act like knives, lacerating these vessels and causing a patient to bleed 3 to 4 liters of blood into their own abdomen. This leads to profound and often fatal hemorrhagic shock. And second, the pelvis is a protective bowl for vital organs. An unstable fracture can drive bone fragments straight into the bladder, the rectum, or the intestines, causing devastating internal injuries. For our final section today, we're going to focus on a detailed case study of one of the most common outcomes of a severe fracture in an older adult, the total hip replacement. Getting a new hip is a modern miracle, but the surgery itself is only the beginning. The critical post-operative journey is what determines success or failure, and it all hinges on the patient meticulously following a strict set of rules to prevent one specific, devastating complication. The single biggest risk in the early weeks after a hip replacement is dislocation. That's the new prosthetic ball popping right out of its artificial socket. Every single one of these rules is designed specifically to prevent that. You must avoid bending the hip more than 90 degrees. This means no sitting in low, soft couches and absolutely no bending over to tie your shoes. Why? Because that deep flexion can cause the neck of the implant to hit the edge of the socket and literally lever the ball out of place. This is also why patients are given raised toilet seats and told to use high chairs. You must also avoid crossing your legs. That motion, which is called adduction, combined with flexion, points the ball directly toward the weakest part of the joint capsule, making it extremely unstable. Patients are often told to sleep with a special pillow between their knees to maintain abduction, or in other words, to keep the legs apart. This helps seat the ball securely in the socket. Following these hip precautions religiously, it's not just a suggestion. It is the absolute key to allowing the surrounding tissues to heal and create the long-term stability the new joint needs to last for decades to come. And so, our deep dive comes to an end. We've journeyed all the way from the raw physics of traumatic force to the precise language of fracture classification. We witnessed the incredible microscopic ballet of cells through the 4 stages of healing, a biological process of just staggering elegance. We've navigated the catalog of terrifying complications that can threaten life and limb, and we've seen the art and science of surgical repair that helps put everything right again. It's a story of both incredible fragility and phenomenal strength. So I will leave you with a final thought to reflect on. After seeing this entire journey, from the moment of impact to the final sculpted remodeling, what do you find to be the single most amazing part of a bone's ability to break and, against all odds, rebuild itself? Thank you for joining me.